Good evening, everybody. It's to my great pleasure that I'm joining you via this record in this very distinguished scientific activity. I'll be taking you through type 2 diabetes in adolescent female. And through this agenda, we'll go into the World Women Day 8th March and why AASD chose to do this, to run this scientific initiative, why it changed the title. While I'm choosing the title, I wasn't that into depth with the literature, and it turned to be better at the youth onset type 2 diabetes. Differences among against type 1 diabetes diagnosis and screening and prevention of complications along the treatment. It's my great pleasure that I stand and I chose to challenge among my professors, Professor Ines Radoud, who took the initiative to celebrate the World Women Day 2021 via this very elegant scientific meeting, which is chaired by Professor Sahar Al-Haini from Minya University, professor at Minya University, and while I'm participating among renowned professors and colleagues from Cairo University, Zagazig University. Diabetes in adolescence is very challenging because according to the Diabetes Atlas, there is only research available for the type 1 diabetes, yet either those with the incidence or those with the prevalence countries are known. But what about the type 2 diabetes in children? Actually, it's known that it's increasing in many countries, but there is no reliable and it has been shown by the American Diabetes Association Youth Onset Diabetes Consensus published in 2016 that doing research in the pediatric or the young young patients age groups are very limited due to the fact that the total type 2 population may be around 25,000 patients at that time, but those who are out of reach to a study or those who are not in active sites for type 2 clinical trials or ages are above 17 years are declining from 25,000 into 6,000, and those who are approached for screening or for real studies are down to 1,000, may be due to the screen failure. That's why data regarding type 2 diabetes in adolescents is very sparse. Many numbers, especially in the diagnosis, is extrapolated from the adult numbers if the SPAD numbers for the children can't be applied. Maybe the type 2 diabetes in children and adolescents had been better coined by the International Society for the Pediatric and Adolescent Diabetes guidelines issued in it has been studied thoroughly that the youth onset type 2 diabetes patients have special characteristics. Maybe by the time type 2 diabetes is being diagnosed in the adult population, almost 50% of the beta cell function had been declined. It had been shown that in the youth age group, 85% of the beta cell had been affected, and there is no insulin, proper insulin excretion, and this deterioration in insulin secretion is a bit more rapid in comparison to type 2, which occur in normal and adult population. Even the obesity is not concerned only seen the obesity is not only seen in those over 18 years of age, but those those younger than 18 years of age. It's rapidly worsening. That's why worsen morbidity and higher mortality is found in type 2 diabetes pediatric patients in comparison with those of type 1 diabetes patients for the same age groups, because type 1 diabetes complications start to show up a bit later, maybe after 5 to 10 years, according to youth onset type 2 diabetes occurs mostly in the second decade of life, in the teenager period. The average age is 13.5. Maybe it shows a bit 1 year later in boys, maybe due to the fact that girls go into puberty earlier, and so more girls are to be diagnosed as type 2 diabetes at younger age, around 10 years, 11 years. It rarely occurs prior to puberty due to the fact that the puberty surge of hormones are associated with higher insulin resistance. That's why this diagnosis occurs mostly around around or after puberty. Most of the youth diagnosed with type 2 diabetes have either family history of type 1 or type 2 diabetes, mostly with type 2 diabetes. It occurs in all ethnicities, but with but in populations with higher type 2 incidence. It had been in today's study, which was held in treatment options for youth onset diabetes, done in the United States. It had been shown that only 6% of those non-Hispanic youth age groups develop type 2 diabetes, in comparison to 30% of the Hispanic age group and up to 76% of the Native Americans. And as you all know, that the Bima Indians, one of the native tribes of the Native American Indians, showed to have the higher incidence of type 2 diabetes and insulin resistance. It had been shown that it's associated with childhood obesity. Those children and adolescents with percentiles of BMI over than 85th percentile are mostly to be diagnosed with type 2 diabetes. Maybe females are more prone to develop type 2 diabetes, but not with a higher ratio, 1.6 in comparison to 1.4 in non-Hispanics. In Hispanics, but 1-to-1 in some other Mediterranean populations at the Libyan ones. It mostly prefers the low socioeconomic and education societies. Some authors have recoined another term of the autoimmune type 2 diabetes, and they refer to it as type 1.5 or type 3 or the double diabetes. Overall, the idea is that maybe autoimmune type 1 diabetes occurs in overweight or obese individuals who have insulin resistance, and there is some sort of intermingling or mixed sort of autoimmunity. There are some uncertainties regarding the diagnosis of youth onset type 2 diabetes, because 30% of those diagnosed with type 1 diabetes or mature onset diabetes of the young are obese or have a background of obesity. And many of those who are diagnosed with type 2 diabetes may present for the first time with ketonuria or ketoacidosis. That's why they were, for the first beginning, they are thought to be type 1, and later they are shown to be type 2. That's why C-peptide measurement or serum insulin are not recommended as routine, especially in the very earlier part of the diagnosis or presentation. Due to the overlap we had mentioned earlier, and due to the glucotoxicity and lipotoxicity, C-peptide levels do not persist as elevated except after almost a year and a half from the point of diagnosis in comparison to type which doesn't occur in type 1 diabetes. Insulin resistance may be found in type 1 diabetes, though is more prevalent, more predominant in type 2 diabetes due to the fact that it's associated with the increased body mass index and increased waist circumference. Monogenic diabetes is rare, but it counts to 5% of cases in running families. It should carry very high rate of suspicion that physicians should be very careful about picking it up. Pre-diabetes concept in youth is very is present. There are a lot of research going about it, and definition is though the adult diagnostic values can't be counted upon, yet there are no other way to diagnose. Yet it is a reversible status, as 60% of the obese adolescent may go back into normal within 2 years from puberty as the hormonal milieu of the puberty wanes. Only prediabetes persists in those who are having persistently weight gain or those who have A1C over 6%. And these are indicative of a progression of type 2 diabetes within 5 years time. There are no role for drugs in the management of prediabetes in youth, and only exercise, limiting caloric intake, and limiting screen times are shown to be very effective in treating prediabetes in youth age, as ISPAD guidelines had mentioned in 2018. What about the screening of youth type 2 diabetes? According to the position statement issued by the diabetes published in the Diabetes Care in 2018, there should be a criteria for screening those youth age groups. Youth is defined by the start of the age of puberty, at the puberty start of puberty, or after 10 years of age. It should be this screening should take place in those who are overweight, whose percentile of body mass index are more than the 85th, or obese by definition over the 95th percentile for the age group. Those who have one or more risk factor associated with diabetes, as maternal history of diabetes, gestational diabetes during this child's gestation, family history of type 2 diabetes in the first or second degree relative, some races or ethnicities as Native Americans, African Americans, Hispanics, and Pacific Islanders. Signs of insulin resistance as acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome in females, and small for gestational birth weight. And according to the SPAD, they added the higher for gestational birth weight babies. They should be screened. What about diagnosis? Diagnosis, though EDA criteria may not be validated in the US, ISPAD criteria may be used. Fasting plasma glucose more than 126 mg per deciliter are for diagnosis type 2 diabetes. Diagnosis should go into 2 steps via confirmation that this patient is really diabetic, and then determining the diabetes type. Confirming is maybe due to, according to the EDA criteria. This is derived from the ISPAD guidelines 2018, and also from the ADA guidelines, the US position statement in 2018. Fasting plasma glucose more than 126 milligram per deciliters post oral glucose tolerance test 2 hours after the oral glucose tolerance test with 75 gram plasma glucose orally, to be given orally, to be measured as 200 milligram per deciliter. Symptoms or signs consistent with diabetes and random blood glucose is more than 200 milligram per deciliter. A1C had been considered as one of the diagnostic criteria as 6.5, but it should be done according to the National Glycohemoglobin Standards Program, Standardization Program, and certified from a certified lab. Then, after confirming that this youth is type 2 diabetes patient, the diabetic patient, then we go into determining which type via doing the autoantibodies, pancreatic autoantibodies, because it had been shown that up to 20% of those with type 2 diabetes in youth have autoantibodies. These are the criteria as derived from the diabetes care with the same numbers as for adults. There are some regarding treatment. There are differences to be carried in mind while we are considering treating type 1 or type 2 diabetes. I'm an adult endocrinologist by studying, but actually in my city we are trying to implement a transition care program where a colleague of mine, endocrinologist, we do consider assessing the youth age together in a team-based and trying to apply the transition care as recommended by the ADA. I will go to this at the end of my talk. Treatment differences had been shown that economic status may carry a very important role, because type 2 diabetes is disproportionate to the population. Type 2 diabetes in youth prefer those with lower education status, with lower socioeconomic status, who have no readily accessible to healthy food and to exercise plans. Though type 1 diabetes is proportionate to all socioeconomic status, and this is clear in the Scandinavian countries, who have a very high socioeconomic status, and they may be one of the higher countries with prevalence of type 1 diabetes. Type 1 diabetes occurs mostly in childhood with parental influence is predominant, while, as we have mentioned earlier, that type 2 diabetes occurs in the second decade of life, where older children have more influence from their peer groups. Type 2 diabetes in youth is experienced in those who 75% is experienced in those that have family experience in type 2 diabetes. The only 5% is found have family experience in type 2 diabetes. Gestational factors are very important. That's why they have been mentioned in the screening program. Those type 2 are exposed mostly to gestational diabetes were born low or high for birth weight, for age. Type 1 diabetes develop complications maybe later than the point of diagnosis, on the contrary of type 2 diabetes patients who may have comorbidities at point of diagnosis and may develop complications very rapidly. Lifestyle is mandatory for all youth diabetes, but is more effective in type 2 and can attain and can help achieving A1C goals with less hypoglycemia. Treatments have two major concerns, two major pillars. The non-pharmacological pillar is very important in the youth age groups and even in the adults, in the pharmacological age group. And the pharmacological age group, on the contrary of the adult type 2 diabetes, we have no plenty of options. The non-pharmacological pillar consists of the education, the behavioral therapy, and the other recreational activities. Education should be a team-based pediatric endocrinologist, an adult endocrinologist, a nutritionist, a psychiatrist, maybe a social worker. It's dependent on the age, on the family involvement, and on the cultural basis, due to the fact that the nutrition is based mainly on the cultural background. It should be done better in groups with the involvement of the family in frequent sessions. And while the behavioral therapy is to be directed at the weight management and decreasing the body weight into the required percentiles. It should have dietary instructions regarding avoiding refined sugars, avoiding processed foods, avoiding junk foods, and to enhance the take of a lot of vegetables, fruits, and to avoid saturated fats. Exercise, physical exercise should be encouraged with the involvement of one family member or one of the peers, especially in the older age groups. Smoking should be there should be smoking cessation, should be zero alcohol, though more studies to be are needed according to the ISPAD guidelines are needed to study more about the complications in type 2 youth patients who doesn't stop smoking. Only in some societies contraceptive counseling should be considered. Regarding the pharmacological therapy, it's according to the point of diagnosis and it's according to the A1C presentation. If the A1C is below 8.5 or more than 8.5, or a patient presented with acidosis. In case of no acidosis or ketosis and A1C is less than 8.5, metformin is to be used twice daily, 500 milligram, and titrated up to 2000 milligram per day. If meanwhile, pancreatic, as we have mentioned earlier, pancreatic autoantibodies to be tested for. If they are presented with no ketosis but A1C is above 8.5, basal insulin should be started with 0.5 per kg per day and titrated or escalated doses every 2 to 3 days based on the glucometer fasting plasma glucose measured at home. And we should empower from the behavioral therapy the self-monitoring of blood glucose at home. Metformin should be added and titrated from 500 milligram per deciliter up to 1000 milligram per deciliter as tolerated if no GIT symptoms. If patient presented for the first time with acidosis or DKA or hyperosmolar ketotic, IV insulin should be started until acidosis wanes, then subcutaneous S4 type 1 is given. When autoantibodies are tested for and revealed to be positive, then this patient is considered to type 1 diabetes and given multiple doses of insulin or pump therapy as indicated in that country or that clinical center or that medical center. If pancreatic autoantibodies are negative, then metformin should be completed upon. If insulin had been there, it should be weaned from gradually according to the glucometer values. If A1C targets are not met, then we can add insulin back again, either basal or with bolus dose. Ultimately, if we fail to reach A1C goals, we have to go back to the other limb of the algorithm where multiple doses of insulin are. It's easy here from the ADA schedule to show that no role for pharmacological oral anti-diabetic drugs for all those less than 18 years of age, except for metformin. Though the so-called gastrointestinal adverse effects had been overcome by the sustained release newer metformin, yet lactic acidosis hadn't been there. No reports about lactic acidosis. Other drugs hadn't been shown safety in less than 18 years of age. Screening and prevention of complications is very integral part of treating type 2 diabetes in the youth. As per every well-known society, the WHO, the ADA, the ISPAD, all targeted addressing the childhood obesity. Screening for hypertension is very important, as it had been shown in the Today study that male gender and higher body mass index had been shown to have increased risk for hypertension in those youth with type 2 diabetes, and it should be measured initially after 6 months. Blood pressure, if it's still above the 95 percentile for age, ACE or ARB can be added. If not achieved, combination therapy can be used, ACE with calcium channel or a diuretic, but never ACE with ARB. Renal ultrasound should be done to rule out secondary hypertension. Screening for albuminuria is very important at the point of diagnosis, and annually thereafter. Definition, maybe this definition is a bit older because EDA had no longer classified as micro and macro. It's always it's either diabetic kidney disease is a micro or a macro present there's albuminuria or no albuminuria. Regarding dyslipidemia, it should be testing for dyslipidemia once the glycemic control has been achieved, or after 3 months of the initiation of treatment, and then yearly after that. Initial lipid panel fasting, it shouldn't be fasting, except we are just suspicious about familial inheritance of hypercholesterolemia. Goal levels for the low density LDL should be lower than 100 milligram per deciliter, and the high density LDL should be more than 35%, and triglycerides should be all the time below 150. Regarding the females, polycystic ovaries is a very common association. Menstrual history should be taken with from every girl presenting with type 2 diabetes, and yet after each visit, evaluation for polycystic ovary, if there is primary or secondary amenorrhea, hirsutism, or acne is there, or if there is acanthosis nigricans. Maybe my colleague Professor Rasha Sobh will go through the polycystic ovary syndrome, had gone through it more thoroughly than I'm just here about talking about the association of comorbidity along with the youth onset type 2 diabetes. Decreasing insulin resistance with weight loss and exercise and metformin may improve the ovarian function and increase fertility, and so in some societies there should be birth control given for girls. Other complications should be considered, The non-alcoholic fatty liver, or then metabolic associated fatty liver disease, counts for 25 to 50% of youth onset type 2 diabetes. Liver enzymes should be measured, and it had been shown that patients who received metformin along with TZDs showed improvement, but not in the age groups below 18 years of age. And so regular treatment for type 2 diabetes in the youth with metformin may improve the liver enzymes and the fatty liver pattern. Screening for depression, anxiety, and eating disorders is very important, because especially at the initial point of diagnosis, youth may be, the adolescent may be not sure about his diagnosis. There may be some uncertainties regarding type 1 or type 2, and the family may show an anxiety, and it should be tackled early. Obstructive sleep apnea accounts for about 70 to 90% of adults who have type 2 diabetes. It's present early in the childhood, but unfortunately, there are no deaths. Here comes the role of the smooth transition of the pediatric to adult care. Youth with type 2 diabetes should be transferred to an adult-oriented diabetes specialist through a smooth transformation and with complete filing system transferred and with counseling and team-based interaction between the pediatric endocrinologist and the adult endocrinologist. I'd like to thank you very much for your attentiveness, and for any comments or inquiries, I'll be very happy to receive them on this email or my messenger account as listed below. Thank you.